Okay. Okay, so first I will be the chairperson for today. So let's first open our session with Surah Al-Fatihah. Okay, so we will go to the trigger first. For our trigger, a 24 years old lady presented to the emergency department with a 3-day history of intractable nausea, vomiting and diarrhea. She was previously well until 6 weeks ago when she started to complain of weight loss, easily tiredness and sleeping difficulty. She was also noted to be easily irritated with new onset of prominent watering eye. On presentation, the patient was agitated, anxious and confused. Her vitals, her vitals shown blood pressure of 160/70 mm mercury, pulse rate of 148 beats per minute and temperature of 40.3 degrees Celsius. He was diaphoretic and flushed with bilateral exophthalmos. There was resting tremors but no peripheral edema. Her thyroid was enlarged and smooth with audible gaze. Her cardiac examination amounts to normal. Other physical examination was unremarkable, and the patient was admitted to the ICU with endocrinology consultation. So before I proceed to the first question, anyone want to comment on our trigger?
So, if we are taking it one by one, the patient is a 24 years old female lady. So it's important we keep in mind that the patient is a young adult at
Sorry,
a reproductive age.
sorry, I can't hear you.
Doctor, sorry, doctor, can you mute your mic? Thank you, doctor.
And also at this age, and being a female, they are at high risk to develop to immunity to other population. Next, the patient presented with 3-day history of intractable nausea, vomiting, and diarrhea. So, patient we can come up with a differential for acute nausea, vomiting, and diarrhea, which are the differential can be due to pregnancy, food poisoning, or acute gastroenteritis. Can also acute appendicitis. However, usually patient will have prominent abdominal pain, traveler's diarrhea due to E. coli or Salmonella infection, Crohn's disease, GI symptoms of GI manifestation of thyroid storm, and we can last but not least is inorganic cause such as irritable bowel syndrome. So patient was previously well until 6 weeks ago. So this means that this is the first presentation. And patient have weight loss, easily tiredness, and sleep difficulty for 6 weeks. At this point, we can come out with few differential. This manifestation can be due to symptomatic anemia due to menorrhagia, or connective tissue disease such as SLE, infective endocarditis, or TB infection,
Salah ni. No, because you go back, okay. Tapi tu turun sikit, okay. Now, you have analysed the patient database kan? Maksudnya this is a case of 24 years old lady. With regard to this, you were supposed to come out with probable diagnosis which is common in this age group and gender. Then you comes the what do you call the complaints that bring the patient to hospital, which is the 3 days history of nausea, vomiting, and diarrhea. So this is your postulation. You said this is the probable diagnosis of your patients. Now, but when you go to the subsequent symptom, which is weight loss, apalagi sleep difficulty, these symptoms were supposed to narrow down your initial differential analysis, in which you say this probably due to pregnancy, due to food poisoning. Bukannya you letak ada possible diagnosis. Kalau macam tu, kalau patient 10 simptom, 100 diagnosis lah you kena entertain. Okay, so your subsequent symptom was supposed to support or exclude your initial differential diagnosis that you have listed in box 2.
Okay, thank you, Doctor. So I would like to include in the 3-day, in the definition for nausea, vomiting, and diarrhea, I would like to include GI flare of SLE. So for the weight loss, sleep difficulty, and easily tired. I can narrow it into pregnancy, Crohn's disease, GI manifestation of thyroid storm, and also GI flare of SLE. Orang lain ada nak tambah apa-apa ke?
As
Any
for
other differential? Okay.
for me, I think weight loss is not. I mean, pregnancy it should be weight gain, right? Not weight loss.
It depends to which semester I talking about or whether patient develop. Okay, the reason why you letak nausea, vomiting, and diarrhea tu you nak represent apa? Masa you kata pregnancy.
Hyperemesis gravidarum.
If you're going to talk about hyperemesis gravidarens, why diarrhea? Diarrhea is not manifestations of the hyperem. Then is the analysis of early pregnancy is correct or not? We expect that kalau hyperem in early pregnancy. If early pregnancy, it means that the possibility of losing weight is still there due to hyperems. Revise your initial differential diagnosis, which is pregnancy. Number 1, food poisoning and AGE is 2 different things. Which one would cause vomiting and diarrhea? Which one would cause nausea alone, vomiting alone, or diarrhea alone? Acute appendicitis is nausea, vomiting in manifestation of appendicitis. Crohn's disease, okay, GI manifestations of thyroid storms, Crohn's disease, nausea, vomiting, again, inorganic cause such as IBS. This is diagnosis of exclusion. GI flare of SLE is very infrequent. Rarely you will have the GI symptoms in SLE. So in other words, the only diagnosis that will be agreeing at this point of time probably is the thyroid storms, probably is the food poisoning, and the rest you need to revise why I say this is less likely. Comments? Comments or defense? Hilang belakang dah. Mana chairperson ni?
Okay. I think we can move on to other points.
My question is that when your friend listed the what do you call the definition that just now, she was supposed to defense or backup why she said this is probably pregnancy, this is what do you call acute appendicitis. Yes, I did mention this slightly because of this, but in the first place, why did you choose to put all this probable analysis or possible analysis in the beginning?
Okay. So for pregnancy, basically because the patient is at a reproductive age and being a female. For food poisoning and acute gastroenteritis, because it is the most common manifestation of food poisoning and EGE is nausea and vomiting.
But again, if you go back to pregnancies, why diarrhea in pregnancy? Nausea, vomiting, yes, I do agree. But why pregnancy would have diarrhea?
I don't know. I'm not sure.
So, siapa yang bagi diagnosis ni? Defense lah, kenapa diarrhea?
Doctor, is it because in pregnancy, a lady can have changes in bowel habits such as constipation and diarrhea? It can be due to diet or added stress.
No, bila you baca buku gynae, year 5 kan? Obstetrics and gynecology, bila you baca buku obstetrics, ada tak dia kata one of the early symptoms of pregnancy include diarrhea? Ada tak? Tak ada kan? Dia ada GI tapi GI upset. Okay, bukan GI loss through the bowel. Okay? So, when you have something which is not tally with the common presentation of the diseases, then you were not supposed to put that diagnosis because diarrhea is not a manifestation of pregnancy. Okay? Next, continue.
Okay, so we proceed with she was noted to be easily irritated with new prominent protruding eyes. So I think because of the protruding eyes, we can include the differential diagnosis of Graves' disease. And then patient is agitated, anxious and confused. It may be a central nervous system manifestation of thyroid storm.
I want to add, maybe she is having the CNS symptoms due to infection such as meningitis or encephalitis.
And then for the blood pressure, 160/70 millimeter mercury, indicated patient had currently had hypertension in hypertensive state. and 148 beat per minute, which is penyakit tachycardia, and also high grade fever of 40.3 degrees Celsius, which is also I think indicative of thyroid storm.
So next patient, she was diaphoretic and flushed with bilateral exophthalmos. So this sign of thyrotoxicosis and also eye signs of Graves' disease. There was resting tremor, but no peripheral edema. So resting tremor also a sign of thyrotoxicosis. No edema, so we can conclude that not conclude. We can say that maybe the patient did not develop complication of hypothyroidism such as heart failure. And next, her thyroid was enlarged and smooth with audible bruit. So there is a goiter with smooth surface. This suggests of Graves' disease, and we can also rule out toxic multinodular goiter and thyroid adenoma because the presentation will be solitary or multinodular. Or audible bruit, it can occur in thyroid storm. So next, her cardiac examination and lungs were normal. This again show that patient did not develop complication of heart failure, complication of hypothyroidism such as heart failure and also atrial fibrillation. And since we suspect it is thyroid storm, so we also need to look for the precipitant such as infection such as pneumonia. So the lungs were normal. We can exclude pneumonia that may precipitate the thyrotoxicosis. And other physical examination was unremarkable. Okay. So that's all for interpretation. Anyone else would like to add, comment, or suggest anything?
Kenapa tiba-tiba normal respiratory expansion, infection, pneumonia, precipitate factors tak faham? Oh, sakit mata tengok.
Because pneumonia can be one of the precipitating
So
factor.
are you trying to rule out or are you confirming that there is a pneumonia?
Rule out.
Okay. So is there anything else that you would like, to highlight or conclude based on the history given? I mean, based on the scenario given. Sebab kalau you tengok ni dia macam bersepah-sepah lah. Bersepah-sepah ni maksudnya information tu dia tak ada benda yang mengikat. When we give you informations by right, there must be something which bind or in medical terms you use as correlate the information given. Okay, so based on the analysis given just now, it was everywhere and did not tie the information given. So bila you nak comes out with the most likely diagnosis, most possible analysis, this won't happen because sampai ke bawah pun dia macam bersepah-sepah lagi. Dia tak ada benda yang this is the most likely that diagnosis that we will give based on the information that we have confirmed and ruled out. So siapa nak summarize cerita ni jadikan satu confirmative scenario so that when you start discussing is this a solid what do you call conclusions already.
Doctor, may I try? So I think for this patient, she is 24-year-old Malay lady, 24-year-old lady presented with the symptom of hyperthyroidism, which is evidenced by there is diarrhea, there is weight loss, easily tired, and then easily get irritated, and also prominent protruding eyes, and it is more suggestive by the physical examination, whereby patient is agitated, anxious, and confused, and she is abnormally sweaty with flushed bilateral exophthalmos, and there is resting tremor, and there is also thyroid swelling.
Let's conclude the history first. So based on the history, you think that this patient have what again?
Thyrotoxicosis.
Thyrotoxicosis. Okay. Based on which one? Which history? Which symptoms actually?
This symptom, first because she is young.
Oh, young tu bukan symptom. Okay, so
Risk factor.
yeah, it's a risk factor because for a patient to have a thyroid, the common age was supposed to be young age, what do you call female gender. Okay, lagi? Why thyrotoxicosis? Why not just hyperthyroidism? What is the difference between these two? Thyroid dengan hyperthyroid?
If hypothyroidism, it is hyperactivity of thyroid gland, which cause increase in synthesis and release of thyroid hormone. But for thyrotoxicosis, it is hyperthyroidism with presence of clinical symptoms because of the increased thyroid hormone in tissue.
With increased thyroid hormone. So tadi kalau hyperthyroidism pun with increased thyroid hormone kan? So apa yang berlaku dekat hyperthyroid tidak berlaku dekat thyroid ataupun apa yang berlaku dekat thyroid tidak berlaku dekat hyperthyroid?
Clinical symptom.
Which one? It happens in which case? Dalam thyroid ke hyperthyroid?
Thyrotoxicosis. You
Okay,
have clinical symptoms.
yes, in thyroid, you were supposed to have clinical symptoms or clinical presentation, whether the symptoms or sign. Whereas in hyperthyroid, the only thing happens is that there is an increase in thyroid hormone. Okay, so my second question is that, so for a patient with thyroid to have a symptoms, to be considered having her symptoms, do they need to have what do you call increased thyroid hormone, or would they present it also without an increase in thyroid hormone?
I think they should have increase in thyroid hormone.
They should have. Can they
Yes.
present it without an increase in thyroid hormone?
Can.
Yes,
Ha,
doctor.
Yes,
oh,
doctor.
ni kau guess ke betul ni? Guess.
Betul.
Betul. Okay. So please remember these two things that we differentiate between the hyperthyroid and also thyroid. Why I'm asking you to remember this, because when we give you a scenario, we might be giving you a patient with a normal thyroid functions, but they still have the symptoms very suggestive of thyrotoxicosis. So this group of patients still be considered having thyrotoxicosis even though the thyroid hormone is still normal. Right now, so in this case, you think that this patient most likely having thyrotoxicosis because he's symptomatic or there was a feature to suggest thyroid. Okay, now beside thyrotoxicosis, what else? Okay, that the history is suggestive to you.
History is suggestive of thyroid storm.
Okay, which symptoms, which features? Because just now when I asked you which features suggested this patient got thyrotoxicosis, you did not come with the features to suggest thyrotoxicosis. So mana symptom ataupun features to suggest thyrotoxicosis, mana symptoms that would suggest the patient got storm actually.
Features suggestive of thyroid storm would include fever, which is indicate of thermoregulatory dysfunction.
No. In our case, the first two paragraph.
This is
Paragraph.
intractable nausea, vomiting and diarrhea. It indicate the
Oh, is it? Aku pandang is it? Is it? Is it tu questions? Kau rasa yang mana?
intractable nausea, vomiting and diarrhea.
Okay, so if we look at these two paragraph, the first paragraph is what they call features to suggest that these patients probably having thyrotoxicosis crisis ataupun thyroid storms. Okay, but there are other things in which that by right you were supposed to list down other differential diagnosis of patient presented with the intractable nausea. The key was intractable nausea, vomiting and diarrhea. Okay. Now, once you have all the list of the differential diagnosis, then you need to come with the supportive history to suggest to support your first diagnosis just now, which is thyrotoxicosis crisis. So in this case, we give you a clue. She got chronic weight loss for about 6 months. 6 years already. She is easily tired and got sleeping difficulties. And on top of that, she was wanted to be irritable and wanted to have protruding of eyes. So these are the things that would suggest that actually all this history is point out towards the presence of thyrotoxicosis rather than all the list of diagnosis that you have presented earlier. Okay, remember I cakap tadi, bila you buat problem list, by right, the next cumulative of the features, the next features would suggest atau would support ataupun would exclude you punya differential diagnosis. Okay, just now bila masuk je second paragraph, dia letak diagnosis lain pula. Okay, jadi diagnosis you tidak bersambung. Sampai mati pun you tidak akan dapat conclusion what is the problem. By right, the subsequent symptom was supposed to support or exclude the above diagnosis. Okay, so at this point of time, we believe that this patient most likely having thyrotoxicosis based on the history given. Now, this is what we call a subjective information because this is what patient claims. Okay, so you need to you need to support the evidence with solid findings. So you do a clinical examination to further confirm your diagnosis. Okay, right. Third paragraph. Pamela. Kenapa senyap ni? Komen lah. You punya third paragraph ni support ke? You know, what is additional information over here? Okay.
So for the third paragraph, there is also signs of thyroid storm, which is the patient mild, agitated, anxious, and confused is a mild signs of CNS manifestation. Also, there is the pulse rate of 148, also sign of thyroid storm, and also the temperature, which is 40.3 degrees, is a sign of thyroid storm, according to the Birch-Wartowski.
Okay. Lagi? Third paragraph. So your third paragraph also support the diagnosis of thyrotoxic crisis or thyroid storms. No? Fourth paragraph.
For fourth paragraph, I think it also support our diagnosis of thyrotoxicosis, whereby he is diaphoretic and flushed with pyrethroid esophthalmos. It gives us a clue about the causes of the thyrotoxicosis, which is grave disease, and resting tremor, also indicative of thyrotoxicosis, with enlarged and smoothly audible breath. Indicate of a diffuse goiter.
What does it mean when there is a statement there was no peripheral edema?
I think that is indicative of absence of congestive heart failure, which is one of the complication of the thyrotoxic crisis.
Okay.
And the examination and lung examination also normal.
Okay, no. Okay, right. At this point of time, there was no peripheral edema. So we were trying to say that there was no right-sided heart failure. Okay. Number dua, because you remember by right, kalau thyrotoxicosis crisis, apa dia punya type of heart failure?
High output cardiac failure.
Apa cardiac failure? Kalau high output cardiac failure, which one is more affected, right or left?
Left.
Left. Okay. In this case, there was no peripheral because we know that left can cause right, right cannot cause left. In this case, there was no signs of right-sided heart failure because remember just now the first chamber to be affected will be the left ventricle. So probably this patient only have the left ventricle failure alone. That's why there was no signs of right-sided heart failure. Okay, you jangan kata there was no signs of congestive cardiac failure because when there is no peripheral edema, so there was no signs of right-sided heart failure. Besides right-sided heart failure, apa lagi kalau peripheral edema ni? Ini tahu. Lawan link sini mah.
Myxedema.
Okay, myxedema. So there was also no other complications of hyperthyroidism, which is the myxedema. Right, now, what is the significance of us saying that there was bilateral esophthalmos?
Grave orbitopathy.
Okay, so we would like you to think of this is most likely grave disease. Remember, when we ask you a diagnosis, okay, you were supposed to come up with a complete diagnosis. If the medical informations, were given in adequate ways, by right, it was supposed to come up with the condition, causes, and complication of the patient. No? Okay, so we would like you to think of there is possibility of Graves' disease because there was bilateral exophthalmos together with the prominence protruding eye. Okay, so further confirms. Right. Now, the thyroid was enlarged and smooth. So in what condition you have thyroid enlargement which is smooth?
Grave disease.
Again, Graves' disease. Huh? Okay. So is there any other case when the thyroid is enlarged but not smooth?
Multinodular goiter.
Multinodular goiter. So we would like you to think of, although this thyrotoxicosis crisis also is common in multinodular goiter, but in this case, okay, we say that the thyroid is enlarged and smooth, so it makes the multinodular goiter is less likely. Now, when we say the her cardiac examination was normal, so it is just to prove that yes, there was no presence of left ventricular failure, okay, and lungs were normal because we would like you to come out with the presence of again left ventricular failure in which there will be presence of pulmonary edema rather than saying that you are trying to look for infections because in your history there was nothing with regard to the infections, okay. And again, when we say that, the second problem is that in your examination, the temperature was 40.3, okay, and you need to look for the source of infections. This is become less likely because despite having hyperparaxia, there was nothing to suggest a source of infections. Okay, faham tak at this point? So before we go to the questions, what is the most likely diagnosis over here? What is the complete diagnosis over here?
I think it is thyroid storm with Graves' disease because
Um,
she presented with thyroid storm symptoms, and together with the graph features like exophthalmos, protruding eyes, and goiter.
Okay, bila you sebut, you jangan cakap with Graves' disease. By right, was supposed to be this patient had actually is a thyrotoxicosis patient, secondary to the Graves' disease, now presented with storm ataupun crisis. So what is the condition of this patient? Okay, based on the history and the mission just now, this patient got underlying thyrotoxicosis rather than hypothyroidism. Okay, what is the cause of this patient to have thyrotoxicosis? Most likely is secondary to the Graves' disease. What is the complication of this thyrotoxicosis crisis? Thyrotoxicosis, this patient now presented with storm ataupun crisis. Faham tak? So if this is your PMP questions, it will be 3 marks at the end of at the end of first questions. Okay, although we ask you what is most likely diagnosis, but I was supposed to say to ask what is the most likely complete diagnosis of this patient because we know that the complete based on the condition, causes and the complication this patient have. So dekat sini markah 3. So kalau jawab macam tu tadi, dia macam 1 per 1.5 lah because it was not predefined which one causing what is the complication, what is the current conditions. Okay, right. Now, continue.
So for the second question, list 2 possible etiologies for the above diagnosis. Two possible etiologies for above diagnosis, which is the thyrotoxicosis secondary to Graves' disease with thyroid storm, is first long-standing untreated hyperthyroidism due to the Graves' disease, and then might be because of second is partially treated thyrotoxicosis. Uh, Maybe the patient have already on treatment. However, she discontinue the medication.
Doctor mute.
Apa tadi causes tadi? Sorry.
Causes dia first sebabkan long standing untreated hyperthyroid.
One is untreated.
Second is partially treated because
Partially
of
treated.
discontinuation of antithyroid drugs.
Okay. So in this case, which one is which? Ada tak information?
No information.
No information is given over here. But look at this patient, she got 6 weeks history only kan. So do you think this is partially treated or untreated?
Untreated thyrotoxicosis.
Again, kalau dia cakap ambiguous. Sebab you remember kalau you all pergi dekat klinik, the common follow up ataupun kalau you tengok textbook kan, bila you start medication, bila sepatutnya repeat dia punya thyroid function, how many weeks after the dose is adjusted?
3 to 4 weeks.
Dengar apa dia?
3 to 4 weeks.
3 to 4 weeks. Bukan 4 to 6 weeks ke? Kau 4 to 8 weeks. Kau 3 to 4 weeks nak cepat sangat. Okay, look balik check bila sepatutnya kita repeat we send another thyroid function test once the dose is adjusted ataupun once you start the patient with the dose. There must be a reason why the blood sampling is done within this interval. It is related to the productions of thyroid hormones. Semua tu sekali lah. Ingat tak? Berapa lama untuk dia buat ke sini, berapa lama dia nak release ke sini. So kalau you faham konsep tu, then you know why we give this interval. Okay? Right. So that would be your first homework for today. Not first lah, second homework for today. Because homework tadi belajar tengok macam mana nak buat differential diagnosis based on the presenting symptoms. Okay, because the rest is actually already pointed out towards the thyrotoxicosis crisis. Okay, third questions.
Third question, do you have any probable precipitating factors for the above pregnancy?
Now, let's talk about our patient. Kalau patient kita ni, which one is most likely diagnosis? Most likely cause lah. No, cause. Kan the precipitating factors kan? There are a lot of precipitating factors, but in our case, which one do you think is more related to our patients?
Non-compliant to antithyroid drugs.
When we talk about precipitating factors, okay, tadi dah ada cause dia, probably this is untreated ataupun this is partially treated. Now, we are talking about the precipitating factors for your patient to have the problems, okay? Now, usually it is related to the major stress. What are the common major stress that will precipitate your patient to get crisis actually?
Infection.
Memang just saya cakap, please correlate with our patient. Okay, she's at 24 years old. If then think of pregnancy as your first differential diagnosis. Don't think of infections. Remember just now, sebab I kata tadi, there was nothing to suggest that she's having a febrile illness. Okay, the only thing that query that she's having an infection because of the temperature of 40 degrees Celsius. Okay, but when you look for the sources, okay, there was nothing to suggest that there is a source of infection. So don't put your infection as the first things, because based on the information given to you, there is no evidence to suggest that she got infected. Okay, so don't put infection as the first one. Pregnancy, I agree. Number 2?
I think, how about psychological stress?
Psychological stress, it is related to recall heavy apa tu, major punya stress lah. So kalau simple stress saja, it won't cause your patient to got a crisis actually. Okay. So any other thing?
Trauma
Jangan
surgery.
surgery tak masuk ward pun lagi. Trauma, yes, I do. Sorry, disconnected. Okay. You jangan letak surgery as your second diagnosis. Patient ni tak masuk ward pun lagi. Trauma, yes, I do agree. Probably trauma, but then, again, it become a questions because it happens for the past 3 days already. Lagi?
Drug,
Drug mana?
steroid macam suplemen.
Why drug cause a crisis? Aku siapa steroid? No.
Diabetic acidosis.
Yeah, again because this is a young lady, think of a medical condition such as diabetic ketoacidosis. Lagi apa lagi common medical condition yang can cause acute stress?
Can it be due to postpartum, doctor?
Sorry, apa dia? Repeat. Boleh repeat tak?
Postpartum?
Well, again, it was not mentioned. Tapi kalau nak fikir pun boleh lah. Okay, si sweet tadi kan? Lagi, post delivery.
How about acute iodine load such as contrasted? Maybe the patient want to do investigation for something else. So CT contrast iodine.
Agree. If you would like to talk about drugs, these are the drugs that we're supposed to look for. Number one is the contrast, the iodine contrast. Okay. Number two is the radioactive iodine therapy. Let's say this patient, in this known case of thyrotoxicosis, went through the REI and then post REI developed this crisis. Number three, drug mana lagi? Okay, number three drug ni cari. Okay, baru beberapa homework, baru 3. Okay, what are the other drugs that can cause thyrosis crisis? Nah?
Amiodarah.
No.
NSAID.
Interferon alpha.
Orang suruh cari beritahu. Tak ada. Bukan. Okay, next questions. Immediate management.
Okay, so for immediate management, I would like to divide to investigation and treatment. So for investigation, under laboratory investigation, same for thyroid function test to look for low TSH and high free T3 and T4 to suggest thyroid.
Kalau patient ada high T3, T4 tapi high TSH, boleh tak?
High free
Boleh.
boleh?
Boleh. Kenapa yang ni boleh?
Overt hyperthyroidism.
Tak lah, ni secondary hypothyroid lah. Primary hypothyroid maksudnya the problems come from the thyroid itself. Secondary hypothyroid, the thyroid problems come is due to
Pituitary.
Secondary things which is probably pituitary. Okay. Lagi apa lagi nak hantar?
Renal profile, because patient have intractable nausea, vomiting, diarrhea, so maybe patient will have acute kidney injury. to look for
Okay.
urea and creatinine. And
Beside AKI, what else is important in the renal function test?
hypercalcemia.
Renal function test tak ada kalsium.
Tak ada. Okay.
Increase
Kalsium memang
GFR.
stand alone. Apa dia?
Increase GFR.
Taklah, renal function test. Apa ada dalam renal function test?
Electrolyte abnormality.
What electrolyte motility?
Hyponatremia.
Why hypernatremia?
Hyponatremia.
Yelah, why hypernatremia? Siapa kata hypernatremia tadi? Why hypernatremia? Penat ke
Fluid
dengar?
retention.
Gana?
Sodium and water retention.
Kenapa ada sodium water retention dalam thyrotoxicosis?
No.
Sama salah.
Sorry, Doctor.
GI losses through vomiting and diarrhea.
So it can cause what? Kalau ada GI loss, dia jadi apa dalam renal function test?
Hypokalemia.
Ada lagi nak sebut natrium. Okay, hypokalemia. Okay, there is possibility of hypokalemia. Number one is due to GI loss. Number two, remember dalam thyrotoxicosis, kan, dalam hyperthyroidism itself pun, okay, there be hypokalemia. Remember the hypokalemic paresis which is common in thyrotox. Bawa associated bukan factors, associated condition. Yang baca buku teks ke tak? Okay, paresis Okay, associated conditions in hyperthyroidism includes, number one is the hypokalemic paresis. Okay, so we were supposed to look for hypokalemia, especially in this case, this patient got thyrotoxicosis. Now, beside renal function test, apa lagi nak hantar?
Liver function test.
Why liver function test?
It look for elevated transaminitis and elevated bilirubin level due to
Why?
hepatic congestion.
Hepatic congestion? Kenapa ni? Kenapa tiba-tiba hepatic congestion ni? Kenapa ni? Kenapa tiba-tiba hepatic congestion ni?
Dia akan cause hepatic dysfunction in thyroid.
Yes, they can have what they call liver dysfunction in thyroid storm, betul. Now, katakan thyroid storm, tapi in this case, what do you think will be the possible findings in the what they call in the liver function test?
Increase liver enzyme.
Patient ni kan
Increase liver enzyme.
apa dia? Why there will be an increased liver enzyme? You ingat tak kalau patient with hyperemesis gravidarum, patient with pancreatitis, patient with severe vomiting, they will also have transaminitis. Ni semua basic adik, basic. Okay, so you look at the diagnosis, you tengok benda apa yang you nak buat untuk confirm ataupun evaluate your diagnosis. On top of that, you were supposed to look for other investigation to assess the other condition. In this case, yes, I do agree bila you tengok, you kata, okay, yes, I know under thyroid function test because this patient presented with thyrotoxicosis. I would like to know to confirm whether she has hypothyroidism or not. Number two, this patient presented with thyrotoxicosis. The other criteria that we would like to look for is evidence of what they call hepatic dysfunction, such as raise in liver enzymes and transaminitis. On top of that, faham tak? That's the reason why you also susah nak excel, because bila you letak benda-benda, you tak tahu kenapa you letak this investigation. Okay, you were supposed to know why I would like to order this. Number one rules is that to confirm or exclude in diagnosis. Okay, number two is that to look for other explanation why this patient presented with these features. Okay, you got all the features, then you correlate. Okay, I dah buat ni, contoh I ada ambil liver function test to look for hepatic dysfunction to support my diagnosis of thyrotoxicosis crisis. Okay, what else can liver function do based on this patient punya presentation? Faham tak? So kalau you tak justify satu-satu, bila kita bagi marks nanti, instead of giving you 2 marks because there is 2 reasons, we only able to give you only 1 mark. Sedangkan you dah bagi dah investigation ni kat situ. Okay? So try to ensure that you fully utilize the investigation that you have requested. Okay, now number 4, investigation.
Blood glucose.
Why blood glucose?
To exclude DKA.
Okay. Now, ada tak apa-apa dalam tu yang probable of DKA? Kalau nausea, vomiting, tu probable lah DKA kan? Ke tak? Orang ni agak-agak je tadi ni. Kenapa tiba-tiba nak exclude DKA?
Dia one of the causes of thyroid.
Sebab I bagi causes tadi. Kalau tak bagi causes tadi, tak fikirlah. Masalah dia sekarang, dia ada diarrhea. Do you think this patient have DKA? Kalau nausea, vomiting, okay, with hyperglycemia, then probably you need to think of DKA. Okay? So by right dalam dia punya explanation just now, you were supposed to request for 1 Dextro stick. Okay? Now, yes, probably you boleh lah nak minta random blood sugar, looking for DKA lagi. Habislah random blood sugar sekejap lagi. Serum lactate kau minta sekali. Apa lagi nak tengok?
Thyrotropin receptor antibody.
Wih, cepat yang kau. Orang cakap ada. Outline your immediate management. Benda-benda yang tidak akan mengubah you punya acute management, you jangan highlight dalam benda-benda immediate. Okay, that goes under your long term plan. In this case, apa yang akan mengubahnya? Okay, number 1 tadi, kalau betul ada decay, then you need to manage decay. Apa lagi precipitating factors?
Pregnancy.
Pregnancy. Do a simple urine pregnancy test. Kalau patient ni ada pregnant, then you were supposed to know what are the things that you can give to patients during the acute problem, what are the things that you cannot give to your patient. So you nak tahu pregnant tak pregnant patient aku ni. Kalau pregnant nanti kan aku bagi kau mazhar, habis lah. Kan? So look for UPT. Lagi? Apa lagi investigation? Investigation tak lepas lagi ni.
Arterial blood gas to look for metabolic alkalosis.
Why? Why metabolic alkalosis?
Sebab patient have diarrhea.
Patient have diarrhea. Tapi kalau dia decay, metabolic acidosis pula. And in fact, kalau dia kata patient ada vomiting diarrhea, by right, it was supposed to be metabolic acidosis because severe dehydration. Mana lagi strong? Metabolic acidosis ke metabolic alkalosis?
Alkalosis.
Acidosis lah. Vomiting, diarrhea. And then, apa namanya tadi, kalau dia ada DKA lagi lah metabolic acidosis, that's the reason why kita tak tengok metabolic alkalosis. What are you going to do kalau patient ada metabolic alkalosis? Kita nak buat apa? Kita buat apa-apa kan? That's the reason why I tanya you, which one is more is stronger? Which one is more important actually? Looking for metabolic acidosis or looking for metabolic alkalosis? Kalau patient metabolic alkalosis, you nak bagi acid ke kat patient ni? Tak kan? kan? Okay, so jangan kata, I nak buat lah ABG nak tengok ada meteorolosis sebab dia ada diarrhea. Okay. By right, I would like to do an ABG looking for metabolic cirrhosis. Again, with the reason of having diarrhea and vomiting. Okay, remember, GI loss can cause what they call cirrhosis due to cells dehydration, ration dehydrated, hypovolemia kan. So, and on top of that, you also would like to rule out presence of DKA. So, metabolic cirrhosis is the most important things dalam dia punya ABG at this point of time. Okay? Lagi? Ada satu lagi penting, ada banyak tapi kalau nak ignore yang lain pun boleh lah. Yang penting-penting pun miss lagi korang ni.
ECG.
Ni bawah blood, termasuk lagi ECG, blood.
Full blood count.
Yes, full blood count. Dengan apa? Kata apa full blood count? Betul lah tu.
For any elevated in white blood cell count.
Oh, tiba-tiba okey.
Hemoglobin level.
Ya tengok apa dulu? Banyak yang kau tengok. Mana kita beritahu kena nak tengok apa, kenapa? Nak tengok apa dulu?
White blood cell count for infection because infection can be one of triggering factor for thyrotoxicosis.
Okay, so apa yang what's expected white cell count finding?
Elevated.
Jangan elevated, wah doktor. Disebut apa?
Leukocytosis.
Yes. Okay, so bila you order what they call complete blood count ataupun full blood count, sorry, sakit mata. You kata I would like to look for leukocytosis, okay, as evidence of infections. Number 2, I would like to look for apa lagi?
Hemoglobin level.
Oh, saat ni ya ada. Saya sebut lagi ke? Dia kena sebut.
Anemia.
Okay, anemia. Which type of anemia? Which type of anemia?
Iron deficiency.
Kenapa iron deficiency? Kenapa iron deficiency anemia? Apa sebab pasien dapat iron deficiency?
Kurang makan.
Amboi, kurang makan. Ramailah iron deficiency. What is the common cause of iron deficiency anemia?
Chronic blood loss.
Chronic blood loss. Okay. Does this patient have anything suggest that she got chronic blood loss?
No.
No. So in thyrotoxicosis or hyperthyroidism or in any chronic illnesses, which one is common? What is a common type of anemia?
Normochromic normocytic.
So by that, I would like to look for normochromic normocytic anemia, evidence for a chronic condition in patient, which is the undiagnosed what they call thyrotoxicosis ataupun undiagnosed hyperthyroidism. Faham tak? Okay? Right. What about platelet? Is there anything important with regard to your platelet? Tak tahu. Okay. Homework. Now there are other blood investigation that you were supposed to order. Please go back and check. Besides blood investigation, there was also urine investigation that you need to order. Beside you punya EBT just now. Okay, now let's talk about ECG. Expected finding in the ECG in this case is
Sinus tachycardia.
sinus tachycardia. Sinus tachycardia is common in thyrotoxicosis.
Atrial fibrillation.
Apa dia? Ada dua suara tadi.
Atrial fibrillation.
In which case? Thyrotoxicosis crisis ke?
Yes.
Okay, now if you talk about thyrotoxicosis crisis, atrial fibrillation is the commonest one. If you talk talk about thyrotoxicosis saja ataupun hyperthyroidism, it means that there is increase in thyroid hormone, then sinus tachycardia is more common. So it depends to which one are you talking about. In this case, because this patient already got a storm, so we expect that this patient will have atrial fibrillations. Okay, beside atrial fibrillation, apa lagi common arrhythmia in relation to thyroid storms? Apa lagi beside AF? Apa dia?
Ventricular fibrillation.
VF tu nak mati lah sebenarnya. Before VF lah, VT. Commonly is VT, ventricular tachycardia. Lagi? Berat kau dengan MCQ tak lepas ni sini ni. Mari tengok ECG findings in thyroid storms. Now, beside ECG, apa lagi yang you nak ada?
Echo,
Apa dia?
echo, radiography.
Amboi kau, mahal terus echo. Okay, boleh lah echo. Okay, what are you going to look for in the echo?
To look for ejection fraction.
Why are you going to look for ejection fraction?
I want to rule out heart failure.
Okay. So what is your expected finding in this patient? Ejection fraction ni reduce ke tak? Dengar.
Normal echo finding.
Why normal echo?
Because in the physical examination and also in the symptoms, there is no symptoms of failure.
Yeah, correct. Because in the information that we have given to you, okay, in the trigger, there was no symptoms and signs such as patient got heart failure. So we expect that this patient will have normal echo findings in terms of ejection fraction. Now, in patient with thyrotoxicosis and complicated with atrial fibrillations, is there any other things that you would like to look for in the echo?
Yes, to look for cardiac embolism.
Yes, you were supposed to look for, jangan cardiac embolism. What do you call LA thrombus? Because we expect that there will be thrombus formations inside the left atriums ataupun left ventricle lah. Okay, right now beside echo, ECG, apa lagi you nak buat?
Ultrasound thyroid.
Ultrasound thyroid, nak tengok apa kat thyroid ni? Ejen.
Retrosternal extension.
Nak tengok retrosternal extension. Kalau kau examine tak boleh. This will change your
to detect any other nodule such in multinodular goiter.
So would it change your management? Mesti kau orang ni tak percayakan diri sendiri. Kalau kau punya sendiri nak tengok retrosternal extension, ketuk, oh tak ada. Okay, ataupun with the history. Okay, do you have dysphagia? Do you have difficulty in breathing? Do you have stridor? Okay, based on your history, based on your clinical examinations, you were supposed to be able to say, unlikely this patient got retrosternal extension. Okay, so that's the reason why we hardly do ultrasound looking for a retrosternal extension unless the patient is symptomatic. Okay, now and then in this case, again, there was no urgent indication for ultrasound because there was no symptoms and signs that the patient got retrosternal extensions. That's the reason why we don't order ultrasound at this point of time. It does not change your acute management. Okay, and then kalau lah ada retrosternal extension at this point of time, what are you going to do? Are you going to put the patients onto the surgical hands ataupun you are going to manage the patient medically? See, the same kind, manage patient medically because you are not going to put patients under GA without render the patients to thyroid stage. Nanti lagi teruk nanti. Okay, now remember this case. There are other imaging that you need to do. Ultrasound is not the important one. Okay. Apa imaging penting at this point of time?
CT scan of the brain.
Okay, ni set mahal berlaku ni. Okay, nanti why are you going to order CT scan of the brain? Patient ni datang dengan nausea, vomiting, diarrhea, easily tired and sleeping difficulty. Dekat situ tak ada indication kan? Kan ada indication? Mana indication dia?
Patient is agitated, confused.
Okay, because the patient is confused. So you would like to know why would your patient is confused? Is there any intracranial lesions causing your patient to be confused? Ni yang minta CT scan the brain pun tak tahu sebab apa nak minta CT scan the brain. Okay, so if you look at the history, there was no indication, but when you examine the patient, as a patient is confused, then you need to order CT scan of the brain. Usually kalau there is no focal neurological visit, we tend to delay the cervical CT scan of the brain. Kalau ada je focal neurological visit, then we'll do an urgent CT brain. Okay, now beside CT brain, apa lagi yang order? Hot senang sekali, hot murah sekali tu order. You need to order chest X-ray. Why do you need to order chest X-ray?
Look for pulmonary edema or kind of infection.
Yes. In this case, you would like to look for pulmonary infections together with the pulmonary congestions. Okay. So this is, one of the things that you need to order because this is common, having what do you call pneumonia, which is undetectable by the clinical examinations. Okay. You need to rule out by sending for chest X-ray. On top of that, because one of the complications of the uncontrolled hyperthyroidism, okay, ataupun thyrotoxic crisis adalah what do you call it, early failure. That's the reason why you need to order the chest X-ray. Now ada lagi tak benda lain? Oh, management. Okay, fine. Lagi? Management pula.
Okay, so for management, would like to admit patient to ICU. Okay, and then assess patient airways, breathing and circulation. Patient have nausea and vomiting, so I would like to resuscitate patient with IV fluid and correct if there is any electrolytes.
So kalau IVD, bagi IVD mana?
Dextrose solution.
Okay, why dextrose? Why not sodium? Kan kalau dehydrated kita bagi je normal saline kan? Kan?
Because patient diaphoretic, sweating.
Oh, so apa kaitan diaphoretic ni? Tak tahu. Kita kenapa kau pilih dextrose? Sebab textbook kata dextrose kan? Kenapa textbook kata dextrose? Argument dia, apa argument dia? General rule, any patient who is dehydrated, hypovolemia, dehydrated, you bagi normal saline because the saline yang akan pegang air. But in this kind of cases, okay, this patient is losing from the GI, vomiting, diarrhea, and then having, excessively sweating. Maksudnya she's having a fluid loss. Tapi kenapa kita choose dextrose rather than saline? Boleh jawab tak? Tak boleh jawab jadi homework. 1, 2, 3. Okay, homework. Kenapa kita in thyrotoxic crisis we choose to give a patient dextrose rather than normal saline, rather than saline actually. Okay, continue.
Okay, so for hyperparesia, we like to give patient paracetamol and for mechanical cooling, like cooling blanket, tepid sponging. And then next, this patient propanolol to control heart rate and also to reduce blood pressure. And but we must confirm that patient does not have bronchial asthma, COPD, and also decompensated cardiac failure. And medication anti-thyroid. The anti-thyroid medication like PTU or carbimazole, metimazole. Okay, and then after that, 1 hour after give PTU, would like to give patient iodide compound like Lugos iodine.
Kejap, tadi kenapa tiba-tiba propranolol lah, tak, beta blocker lain tak boleh ke?
Because it has apa ni? It has a role in reduce the peripheral conversion of T4 to T3.
It's because by right kita kata kita akan bagi any adrenergic drugs ataupun any beta blockers, because our initial aims is to reduce the symptoms kan, the what they call sympathetic symptoms kan. Okay, but among all, why we choose propranolol on top of comparing to atenolol or metoprolol or labetalol, because it has additional effects in terms of the conversions of T4 to T3. On top of that, selain pada itu, remember the rest of the drugs tu, dia punya apa effect dia ataupun action dia to reduce BP is more potent compared to propranolol. Kita punya aim nak reduce heart rate, bukan nak reduce blood pressure. That's the reason why we tend to give propranolol, because in terms of the BP reduction, it is much lower compared to the drugs. Dia akan improve the heart rate, but in terms of BP, it's just not as potent as the other rest of the drugs lah. Okay, now in terms of anti-thyroid, PTU and metimazole, you nak bagi mana?
PTU.
PTU?
Why PTU?
It inhibit peripheral conversion of T4 to T3, and also it has protein binding.
Apa? Is a protein binding?
It has a faster onset.
Yes, it has the what they call onset of action is earlier compared to metimazole. Such a reason why we tend to choose PTU compared to metimazole. But again, it depends whether your patient can take the medications orally or not. If your patient can take medications orally, which one you bagi? PTU ke metimazole? Katakan patient tak boleh makan, maksudnya memang very confused, agitated, not cooperative, dia nak bagi apa sir? PTU ke metimazole?
Metimazole.
Sebab PTU tak ada dalam bentuk intravenous lah, so we tend to give metimazole. Okay, next medication. Continue lah, Lugos ID tu. Sorry, saya sakit mata, silau sangat. Tak boleh buka mata yang terang.
For Lugos iodine, we must give 1 hour at least after we give PTU. And then a high dose of IV dexamethasone.
By right, again dia macam tadi lah, macam tadi kita sebut beta, anti-adrenergic drugs, the thionamides, the iodine, ni cakap terus nak bagi Lugos, because there is other options of the iodine, which is the potassium iodide kan. And then commonly we use the Lugos compared to potassium iodide. Okay, so bila nak mention, dia cakap mention iodine je lah, such as Lugos iodine ataupun potassium iodide. Okay, now lepas tu nak bagi steroid, high dose steroid. Okay, continue. Cepatlah glucocorticoid tu. Kenapa nak bagi glucocorticoid? What are the alternative that you have beside dexamethasone?
Hydrocortisone.
Okay. So kenapa you nak bagi?
to have both role of inhibit thyroid hormone and thyroid hormone synthesis and also inhibit peripheral conversion T4 to T3.
Sorry, apa dia?
Can inhibit both thyroid hormone synthesis and also peripheral conversion.
Okay, is it reduce peripheral conversions of T4 to T3. Okay, beside that, apa lagi dia punya additional effect dia? Additional effects of glucocorticoid.
Reduce hypermetabolic state in thyroid storm.
Macam mana?
Help in treating the adrenal insufficiency in thyrotoxic crisis.
Apa dia? Tak clear.
Reduce the adrenal insufficiency.
Okay, dia prevent relative adrenal insufficiency. Remember dalam ni kan dia hypermetabolic state, so dia macam overutilizations of the cortisol kan lebih kurang lah pemahamannya. Okay, faham konsep tu. Okay. So there be a relative adrenal insufficiency. Sebenarnya cortisol cukup tapi because the high metabolic rate menyebabkan macam cortisol tu macam relatively insufficient. So by giving steroid, so it is prevent this relative adrenal insufficiency. Okay. Next medication.
Lithium, if patient cannot use iodine, allergic to iodine.
That will be the alternative. Beside that, the final one is the bile acid sequestrants. Right? So there are other drugs which is called bile acid sequestrants. This is meant to prevent the reabsorption of the free thyroid hormones in the guts. Okay, so bila kita bagi classes ataupun type of medication, then you were supposed to mention, okay, kenapa nak bagi contoh bile acid sequestrant, because we would like to reduce reabsorption of the free thyroid hormones in the gut. Why will you give your patient glucocorticoid? Because we like to reduce peripheral conversions of T4 to T3. So you can bagi, okay, nak bagi this drug, this group of drugs for this reason. Contoh dia apa? And sometimes they will ask how much that you're going to give, what is the interval. Tapi yang konsep asal dia, which drug are you going to give? Why are you going to give the drugs? Must be mentioned macam tu. Okay? Now, is there any other things that you like to do for these patients in terms of the management?
Plasmapheresis.
Okay, rarely we do plasmapheresis. This is only reserved for the life-threatening conditions. Okay, right. Is there any other things? No, remember. Apa dia?
Can we give antiemetic because patient is having vomiting, nausea and vomiting?
Boleh lah. Well, because that one is only symptomatic and this vomiting ni, nausea ni is due to the hyperthyroids. One, the hyperthyroids, what do you call the thyrosis crisis is resolved, then your patient should not have nausea vomiting. Kalau nak bagi pun tak apa, tak bagi pun tak apa. Tapi the more important one adalah, remember just now, there are major event ataupun major conditions that precipitate your patient to get the storms. Okay, so then you were supposed to add you punya information by saying that if there is evidence of acute infections, I would start to giving this patient antibiotics. If there is diabetic ketoacidosis, I would like to do this and that. Okay, so go back to your precipitating factors just now, and you need to come out with a brief descriptions what are you going to do with regard to the precipitating factors. Okay, right. Now, next questions.
So to the last question, outline the long-term plan of management. First, we need to confirm our diagnosis, the causes of thyrotoxicosis. So I would like to do thyroid ultrasound. Expected for if suggestive of Graves' disease, the PSV is of inferior thyroid artery is more than 40 centimeter per second. And then secondly, we do thyroid receptor antibodies, TRAB. It's a specific biomarker for Graves' disease. And also the last investigation is thyroid scintigraphy. We will see if there is an increase and diffuse uptake. It is also suggestive of Graves' disease.
Okay, to summarize your long-term management, okay, Myra, you were supposed to talk about the thyroid autoantibody. So, which antibodies would suggest this is due to Graves' disease? Which antibodies would suggest this is due to toxic adenoma? Which antibodies suggest toxic multinodular goiter and whatnot. So you were supposed to come up with this thyroid antibodies. And number two, because these are the things yang akan differentiate. Remember, long term you already put the patients in the stable conditions. Maksudnya dah out of crisis, only having thyrotoxicosis. Now this is your time to look for the possible reasons, the cause of your patient to have thyrotoxicosis. So these antibodies would differentiate which diagnosis that your patient is having. Number two, investigation that will differentiate is the scintigraphy. Okay, so the scintigraphy will show, yang kalau apa nama, kalau toxic what do you call goiter saja, will be diffuse apa nama area diffuse area pada diminish areas of uptake. Kalau multinodular goiter dia akan ada irregular areas of diminished uptake. Kan dia line pattern dia. Okay, kalau patient ada Graves' disease, there be a diffuse enlargement with increased uptake. Kan? So dia akan the scintigraphy akan membezakan which which thyroid problems that your patient is having at the moment. So these two need to be ordered. Tapi kalau ultrasound tu kita because there is no added value by ordering ultrasound. You just beritahu ada thyroid, tak ada thyroid, macam tu je. Kan thyroid is enlarged or not enlarged, tu je. Okay, walaupun cakap tadi kalau measure the what do you call how the thickness of the apa tadi thyroid artery tu, kita orang memang tak pernah buat, kita orang memang tak pernah peduli pun because it does not had any additional values. We only order ultrasound for ultrasound assisted fine needle aspiration cytology if we would like to have a what do you call a tissue diagnosis, tu je. So remember, in what do you call thyroid problems, non-surgical thyroid problems, the ultrasound hardly is indicated. Kalau imaging is more of scintigraphy rather than ultrasound. Okay, right. What about the management? Is there any other things that you can do for these patients in terms of the management?
In terms
Treat
of
the
management,
okay.
treat the hypothyroidism. So we can give our first line treatment will be anti-thyroid drug, either PTU or metronidazole, but preferably metronidazole because we can give a single dose per day because it has a longer action rather than PTU. And then if medication fail, we can opt for radioactive iodine.
So how long are you going to give, with regard to the, what do you call, anti-thyroid drug just now, okay? Number one, I dah beritahu tadi, you kena cari bila you nak repeat the thyroid function test so that you can adjust the anti-thyroid drugs. Number two, bila you expect that patient will show some evidence of remissions, okay? Number three, bila you nak decide this patient has a failure to the anti-thyroid therapy, so that you are going to subject your patients to the RAI. Yang tu you kena balik carilah. Boleh? Kena bagi tahu terus.
Doktor, for yang repeat test tu 2 to 6 weeks after anti-thyroid drug.
Tak sebut kata 2 to 6 weeks. Kenapa? Kenapa?
Tak tahu.
Cari dia punya underlying reasons why it was supposed to be repeated 2 to 6 weeks. Okay. In terms of practicality, usually we repeat after 4 to 6 weeks. Because that's must be a reason why we ask for 2 to 6 weeks, and that is explained by you expect that the result the changes will be seen between 2 to 6 weeks. Cari reasons ya lah. Now, lagi beside the anti-thyroid therapy, any other things that you would like to subject your patients to ataupun add onto the anti-thyroid therapy?
Radioactive iodine therapy.
Nanti dah tu lepas yang ni fail dulu baru RAI. Yang ni tak fail lagi. Okay? You need to consider to give beta blocker to relieve the neurologic and also cardiovascular symptoms. Once patient dah tak ada all the sympathetic punya activity reactions, then probably you can off the beta blocker. Lagi? Remember just now your patient got protruding eye. Siapa yang boleh buat dengan mata dia?
Eye drop and
sunglasses. Okay. Dia punya keywords adalah tight fitting sunglasses because dia memang tak nak masuk pun. Because tidak nanti mata dia ni senang dry nanti dapat cornea ulcers. So it must be a tight fitting sunglasses and a frequent eye drops. Okay? Right. Any other things? When are you going to consider your patient subject your patient for thyroidectomy?
When patient has compression symptoms or failed medical treatment.
Okay. When you have a compression symptom, agree. Failed medical treatments including RAI, agree lagi?
Compliance issue?
Yes, patient who have compliance issues, especially kalau pregnant lady. Okay, lagi? Beside large goiter tadi, apa lagi? Tadi large goiter yang can cause the compression. The eye, severe ophthalmopathy also is one of the indication. And there are other other reason why your patient was supposed to be subjected for thyroidectomy. Nanti yang itu boleh tengok
Suspicious of thyroid malignancy.
Cosmetic purposes.
Yes, cosmetic purposes betul. Suspicious of thyroid malignancy. Yang tu taklah. Usually that's why kita buat looking for the tissue biopsy. Tissue biopsy is confirmative. Buat scintigraphy. Very suggestive, then we put your patient for thyroidectomy. Okay, lagi? Lagi tak?
Pregnancy.
Dah cakap dah, pregnancy especially, non-compliant especially in pregnancy. Okay, because it will be a risk to the mother and also to the fetus actually. Ada lagi tak apa-apa? Okay, is there any more information that you would like to add or questions to ask? Saya minta maaf, saya memang sakit mata sangat hari ni, tak boleh buka mata kuat-kuat. Buka kuat, tak boleh buka mata luas-luas. Saya tak boleh nak tengok. Okay. Is there any questions?
Doctor, I have a question. If the patient having a thyroid storm, and at the same time she presented also with a hypertensive crisis, so should we manage the patient to both thyroid storm and also hypertensive crisis juga, ataupun kita manage the thyroid storm tu saja? Because we know that thyroid yang menyebabkan hypertensive crisis tu.
Okay, faham. It depends to why you label a patient to have hypertensive crisis, no? Now, kalau memang masa tu tak ada stroke tak ada heart failure, tak ada acute coronary syndromes, it's quite easy is go back to the basic. Contoh, this patient got a very high BP due to thyrotoxic crisis. Okay, now one of the treatments that you give to your patients adalah the beta blocker just now. So rather than you choose for propranolol to control the heart rate alone, you were supposed to choose a beta blocker that will control the heart rate and also reduce the blood pressure, which is commonly used to for fast control of the blood pressure is the labetalol. Then you opted for labetalol. Okay. On top of that, because one of the complication, let's say you say this patient got hypertensive crisis, complicated with the heart failures, then you can add on the furosemide, the diuretics on top of that. Okay, but be careful because kalau heart failure, you tak boleh bagi dah beta blocker. Ataupun kalau you berani, you bagi tapi small doses with the close monitoring. Especially in this case, kalau patient ni memang dah you label as storms in the ICU, we all tak worried sangat. ICU maksudnya INS ada sebelah. Ataupun dah siap-siap intubate kan. So, kalau patient nak intubate, you bagi beta blocker, patient goes to fluid overload, tak apa, patient dah ventilated. So, the ventilation has been taken care of already. So, just need to add on the diuretics to reduce the what do you call the fluid. Okay, so konsep ni sama. If you manage to, if you're able to manage the cause of your patient to get that condition, in this case thyroid storms, then you'll be able to revert to the condition which is the the crisis. In this case, for instance, heart failure kan senang. Okay, right. Any more questions?
Apa explanation untuk thyrotoxicosis with normal thyroid function test? Maksudnya thyroid dia memang normal ataupun kita tak dapat
Dia tak kata thyroid yang normal, dia kata thyroid hormones yang normal level. The level of thyroid hormones, you remember yang we call a subclinical hyperthyroidism tu kan? The thyroid hormones is normal. The TSH is on the low side because the thyroid hormones, has not been accumulated as yet lah. There is a response to the low TSH tapi tak sampai level of increased thyroid hormone. At this point of time pun, patient boleh develop juga the crisis. Faham tak? We don't say that this is 100% normal. So it looks like normal. The abnormal thing is that this patient already got a suppression of the TSH due to hyperthyroidism, which is not detected at this point of time. Nak puas hati lagi, buka buku ni. Buka buku Harrison. Harrison, dia cerita panjang-panjang. Cari yang tulisan dalam kotak tepi ni yang kecil-kecil. Ini lagi detail penceritaan dia. Harrison lah. Okay, any more questions?
Doctor, for eye symptom in Graves' disease, after medication, can it be repeated?
Susah sebenarnya. Dia it won't go back to 100% kalau ikut textbook and based on our experience kan. If it goes back pun it's not 100%. Some of them not even go back to normal. Some of them already bukan defisit lah. They already develop the corneal ulcers, scarring and whatnot, so they will left with that apa panggil? Bukan disability, benda that complication lah. Benda tu still ada tapi dia tidak akan progress, and then kalau dia revise pun improve, bukan revise, dia improve pun it's just a little bit improvement tu je. And some of them in fact bila yang thyroid hormone dah normalize, so they need to go to have a repair of dia punya ni lah eyeball, because kan masa tu dia involve juga dia punya muscle contraction and what not. So some of them need also to be subjected for ophthalmology punya surgical procedures. Jangan tanya I apa dia, tapi dia buat lah surgical procedures kan. Jangan tanya I what type of procedure, I tak hafal. Okay. Okay, any more questions? Is there any more questions?
Doktor, I have question.
Okay.
Untuk remission, kiranya kita katakan dia remission bila thyroid function dia normal. Tapi kalau dalam Graves' disease, is it the thyroid, bukan thyroid, caseous receptor punya antibody tu dah tak ada baru kita cakap remission ke?
No, we never measure dia punya antibodies once we start treated the patient. Kita measure antibodies tu hanyalah untuk tengok why the patients develop the thyrotoxicosis, which thyroid problems. So once we just confirm this is due to Graves' disease ke multinodular or whatever, not kita tak buat dah dia punya thyroid antibody because number one is too expensive. Number two, because we know that when the antibody is there, it is there lah. Cuma whether we were able to control the patient's thyrotoxicosis conditions to become stabilized or not, itu je. Kalau ikut experience-nya, kalau Graves' disease ni usually it takes quite longer times for them to go back to remissions, and sometimes they will have a relapse after that. Okay, so if you read your textbook, it's also mentioned because the antibody is still there, cuma whether it becomes active or not. Okay, any more questions? Okay, if there is none, thank you for today. Sorry, I memang tak ada tengok muka you all. Silau, I dah habiskan zero dah. Tak boleh juga. Okay, thank you. Good luck. Okay, Assalamualaikum.